Hi there, my name is Lindsay Richardson and I am going to be spending the next little while with you focusing on health inequity under COVID-19. Importantly, we're going to focus on why COVID-19 doesn't affect us all equally, how that happens, and why it's important. And over the course of the next 3 modules, we're going to deal with 3 topics. The first is general background around health inequity and what we should be focusing on and thinking about when we think about health inequity. Secondly, we're going to do a section on pandemic patterns and what is happening around health inequity under the pandemic and because of the pandemic. Lastly, we're going to focus on syndemics under COVID-19, and here we're going to talk both about the idea of what a syndemic is and to talk about a local example of how syndemics are really relevant and active at this current moment. And so, to start, we're going to talk about health inequity and give a bit of background. And here I really want to distinguish between the idea of health equality, where everyone is offered the same tools and the same policies and the same frameworks and expected to move towards a similar outcome. And health equity, where individuals are given tools that are specific to their particular circumstance to better support the idea that we can all have the same health outcomes or all strive for the same level of health. And we're going to start here. This is a picture of the traditional epidemiologic model of disease. And the idea is that the interaction between the agent, which is the virus, in this case, that's a picture of a COVID-19 molecule, the host that the agent infects, in this case, people, and the environment in which the agent and host interact. Here, the places where we live and work and travel and are treated in health contexts interact to produce a given burden of disease. And the idea is that each of the agent, the host, and the environment have a set of variables that affect the degree to which an infectious agent like COVID-19 is going to take hold in a population. I would like to add a bit of sociological understanding into that model. One of the weaknesses of the model is that it doesn't necessarily think through how things related to susceptibility, so in terms of the host, and things related to exposure, so the environment, are socially organized and have sociological underpinnings to them. And in the first instance, if we think about the susceptibility of the host, we know that has to do with an individual's physiology. So, for example, how strong their immune system is, and pre-existing conditions. So the degree to which their body is already managing other health diseases or disorders. We also know that susceptibility is related to health behavior, and then it's related to social identity. And health behavior, for example, might be whether or not someone physically distances appropriately from other people. And social identity might be things like your gender identity, your sexual orientation, your gender, your race, your age, those kinds of things. Exposure, or the environment in which the host and the agent interact, often is related to the degree to which the disease is already taken hold in a population. How common is it? It is related to whether or not there is a vaccine available, and we of course know that at this point in the summer of 2020 there is no vaccine available for COVID-19. Exposure is also related to the physical, social, and economic context in which people live. So do they live in poverty? Are they able to physically distance? To what extent are they able to socially stay away from peers and colleagues? That environment is also related to political and legal systems and health policy. The degree to which political leaders take an infectious outbreak seriously, the degree to which people might be supported in their behavior or criminalized and placed in institutions, and the degree to which health policy is able to support public health action to counteract an infectious disease. And what we know is the interaction between the susceptibility of the host and the exposure that they have in the environment and the interaction of a very complex set of factors really affects who gets infected and why. And we know that because of the interaction, people are unequally prepared and unequally able to prevent infection, that they are placed at unequal risk of infection, and that for those that become infected, that there is unequal access to treatment and unequal recovery pathways. And so the degree to which the susceptibility and exposure are socially organized really has a lot to do with what the burden of disease is at the end. And so we're going to focus a lot on social identity, and specifically race and gender and socioeconomic status, to give you just a bit of background about how these things are patterned and why it matters for infectious disease. In terms of sex and gender differences in health, we know a few things. There's been research that's been done on this for some time. For example, we know that females and women live longer than men and transgender individuals. We also know that there are sex and gender differences in major causes of death. So, for example, males are more likely to die from most cancers, from respiratory and heart diseases, and from injuries and accidents, whereas women are more likely to die from Alzheimer's, from influenza, from breast cancer, and from some circulatory diseases. We also know that women and females are more likely to be diagnosed with mood disorders, and that women and females utilize more health services, not necessarily because they are more ill than men, but because they are more willing to go to see the doctor or more willing to seek out care. And so the question then becomes, why is that the case? Why do we see these gendered trends in long-term health outcomes? And there are a number of sociological explanations for these gender differences in health. I'm going to go through them briefly here, but you could really go down a rabbit hole with any of these explanations. The first one has to do with social roles and social role theories. And the idea here is that things could go either way. So more social roles might result in better health because they bring things like self-esteem or social support. And a social role could be like a mother, a friend, you could be professionally involved, those kinds of things. The unfortunate downside of that is that too many roles can result in worse health because of stress and the impact it has on health, and interference with women's capacity or people's capacity to engage in good health behavior related to, for example, nutrition and diet, to exercise, and to sleep. So that's one set of theories. Another set of theories is structural inequality. And here, what would point to here as sociologists is that the unequal distribution of wealth, power, and privilege between women and men has direct and indirect effects on health. So directly, it might have to do with the fact that women make less money than men for doing the same roles and might therefore have fewer resources available to them. We also know, for example, that there is a lot more research done on men's health than on women's health. And all of that structural inequality accumulates over time to affect health differently. We also know that risk-taking and socialization are gendered, and I'm realizing there's a typo in the slide there. However, what we mean by that is that the likelihood that someone engages in a particular risk behavior, such as drug use or activities that might lead to an accident or poisoning, are socialized in gendered ways. Related to that is the idea, for example, of toxic masculinities. And here, what we know is that masculine social pressures may lead to neglecting health. So it may lead to people not sleeping, it might lead them to have less healthy eating patterns, and it also might lead them to underreport health issues and not seek out care. So those are the general explanations for why there are gender differences in health. If we turn to race, we also know that there are racial and ethnic differences in health. And in terms of major trends here, there are a couple of points that I think are important to emphasize. The first is the idea of first and worst. And the idea here is that visible minorities experience earlier onset and greater severity of disease. And so what that means is that they are younger when diseases first appear, and when diseases do appear, they are more severe. So for example, African American women in the United States and Canada have breast cancer much younger than white women, and they also have more severe breast cancer than white women. So that's the idea of first and worst. The second thing worth noting is non-equivalence. And the idea here is that the things that affect our relationship to disease and illness don't affect everybody equally. So similar exposures are known to impact disease produce different outcomes among different racial groups. And this is not necessarily because of factors inherent to race, but often because of the social organization of life and work for different racialized groups. We also know that things that are protective against disease are not as protective for people of color. So the idea here is we know that people who have higher levels of educational attainment generally have better health outcomes. But if you, for example, take a group of people of color who are physicians and take a group of white individuals who are physicians, even at that same level of education and status, the group of physicians who are people of color will have worse health outcomes. And so the idea there is that education is not as protective for people. It's not equally as protective as it is for individuals who are not members of racial or ethnic minorities. And so why does that happen? So there are also a number of sociological explanations for why that's the case. And a lot of these, in the context of the current social and political environment, are going to be very familiar to many of you. The first is institutional racism. And the idea here is that policies and procedures nested within institutions often reduce access to resources. And this is true even in the modern era, and even with the idea of sort of colorblind policy that has been on vogue at various points over the last several decades. And so we know, for example, in the United States, that formal segregation of black and white populations was ended many decades ago. But what is sort of less well known is that segregation happens even in the absence of those policies for a range of reasons. And so the institutional racism that results doesn't recognize the racialized impacts that different policies might have and how those affect health. Similar to the relationship between women and men, and recognizing there's another error in my slide here, that should be the unequal distribution of wealth, power, and privilege between visible and non-visible individuals, has direct and indirect effects on health. And again, here we're talking about people not earning as much, not having decision-making power, there being research gaps, etc. We can also talk about cultural racism, and the idea here is that there are negative prejudices and stereotypes that shape discrimination and opportunity structures, for example, related to work. This could also be related, for example, to property ownership or wealth accumulation. And what we know here is that cultural racism and the way that it is embedded in our day-to-day lives really shapes discrimination, and that shapes people's opportunity structures. And finally, we have experiences of discrimination themselves, and these experiences of discrimination produce stressors on the body, and these can range from overt experiences of discrimination to microaggressions and everything in between. And those stressors on the body actually produce changes in physiology and health behavior. So whether or not you are subject to police violence bearing witness to police violence and witnessing someone else's experience of discrimination produces stressors on the body that are not equally distributed in the population. So these are the sociological explanations for race and ethnicity differences in health. Lastly, we're going to turn to socioeconomic status differences in health and talk about some of the major trends there. First, people with higher socioeconomic status have better health outcomes across different diseases for most measures of socioeconomic status. So that is, people who have higher incomes, higher occupational status, higher levels of wealth, higher educational outcomes, they all have better health outcomes in general for most diseases. We also know that relationships between socioeconomic status and health tend to be spatially distributed. So the idea here is that wealthy neighborhoods tend to report better health outcomes than poorer neighborhoods. And you can think about that across a number of different spatial dimensions. Third, places that have more inequality have worse health outcomes for all levels of socioeconomic status. And this is a bit more complex, but the idea here is it isn't just about the absolute difference in socioeconomic status between one person and another person. The idea here is that the relative difference between the highest and the lowest members of a given city or province or country affects everyone's health outcomes within that geographic space. And we'll talk a little bit more about that in a second. And lastly, we know that the relationship between socioeconomic status and health follows a gradient. And so what does that gradient look like? That gradient looks like this. Essentially, at every level of socioeconomic status, you have an incremental increase in the impact on someone's health outcomes. And so it isn't just about high income versus low income. People at the highest of high incomes have slightly better health than people who are just high income, and so on. And so the idea here is to remember it's not just about good or bad, it's about this incremental, stepwise relationship between levels of socioeconomic status and health. And so we know, for example, this is going back to the point number 3 on the previous slide, where we know that more unequal countries have worse health outcomes across a whole range of outcomes. And these are listed here. And so you can see that Canada falls somewhere in the middle, that Japan has relatively low income inequality and relatively better outcomes across a whole set of health and social indexes, and that the United States has very high income inequality and also has worse health. And this is a trend that we see across a whole bunch of different indicators. In Canada, and I recognize these are a little bit fuzzy, I hope they turn out better in what you're looking at, but what we know is that for men and for women, there is a gradient by income quintile and sex and gender. So that gradient that I mentioned before is very much true in Canada, and it might not seem like a very big difference, but it is a noticeable difference. And for example, if you look at the difference in life expectancy at age 18 by income quintile, so this is additional years of expected life when you're 18 years old. If you look at the highest income quintile at the very bottom, men have a life expectancy of 60.7 years. Men in the lowest income quintile have a life expectancy of 47.7 years. So that's a difference of 13 years between the lowest income quintile and the highest, and that is very significant. We also know that there are inverse gradients when we're looking at negative health outcomes. And so here what we show are suicide deaths by income quintile separated by sex and gender in Canada. And you can see both sexes combined at the top, followed by women, and then followed by men. And again, what you see here is there is a very large difference between men in the lowest income quintile and men in the highest income quintile. And that difference that death rate difference is very significant in real terms. So why the socioeconomic gradient, and why does socioeconomic status matter? The basic explanation in the sociological literature relates to fundamental cause theory, and this explains the enduring association between socioeconomic status and health despite changes in diseases and risk. And so levels of risk can change over time, and the disease that we're talking about can change over time, but essentially, no matter what disease we're looking at in whatever time period, we see this difference in health outcomes according to socioeconomic status. And the core concepts behind this explanation are that socioeconomic status embodies flexible resources. So money, knowledge, prestige, power, social connections. You can take resources and turn them into a lot of different things. And that these resources are protective for health no matter what the mechanism or pathway is relevant at a given time and place. And so you could think, for example, about polio. And when polio was an infectious disease that was having very significant outcomes, people were able to protect themselves against polio if they had more resources. And the same is true today, and we'll talk about this in the next section when we talk about COVID-19 and socioeconomic status. Resources are available to protect health no matter what the disease and no matter what the mechanism or pathway by which people become infected. The implications of fundamental cause theory for health policy are important in that they identify how important it is to reduce resource inequalities between individuals. So it's not just about helping people out, it's about reducing those inequalities. It's also important to remember that we must contextualize risk factors. And so what the idea here is we need to be thinking about how the differences in socioeconomic status are produced. And so as opposed to just saying someone's at risk if they're homeless, we need to think, what are the reasons for which an individual became homeless? And the idea here is that in order to address these health differences by socioeconomic status, we need to understand the risk of being at risk of something and the cause of something. And that might seem a bit complex now, but if you are interested, there are lots of additional resources that you can look at related to fundamental cause theory that explain this a little bit better. Lastly, it's also what this tells us is that in terms of health policy, we should really be prioritizing interventions that minimize the relevance of resources. So we should be prioritizing interventions that make it so that even if you don't have a lot of resources available to you, that you are able to benefit from those interventions. And these are interventions that are universal and automatic, right? So things that just happen without people having to initiate them and that are available to everybody in the population. So, bringing that all together, if we think about health inequity and the background that we've gone through, the general gist is that the epidemiologic model of disease is limited in that it fails to take into account the social patterning and structural context of susceptibility that occurs in the host and exposure that occurs at the level of the environment. We also know that there are persistent inequities in health across lines of disadvantage, and the lines of disadvantage that we've talked about today include gender, race and ethnicity, and socioeconomic status. And we know that these inequities have institutional, social, structural, and cultural causes, and that the idea of trying to promote health equity in individual outcomes requires intervention in all of these spaces. So we'll leave that there, and I'll look forward to having you back for the next module.